All right, so I'm just going to have the pleasure of introducing the panel moderator, Deborah Scammon. She's founder and director of the University of Utah's Master of Healthcare Administration program. She has extensive experience in coordinating and facilitating interdisciplinary teamwork and program management. She is a co-investigator. She has been a co-investigator on a PCORI Tier 1, and she is now currently an investigator on a Tier 2 project. And she focuses on engaging a community of patients and caregivers who have experience with the stresses of managing care needs of the elderly. So extremely important topic, and she's going to have us talk about PCORI research in Utah.
Unmute, can you hear me? Sort of. No? Maybe it's not close enough. No. Okay, can you hear that? All right. So I'm going to stand up just for a second because my first activity is going to be to introduce all of the panelists. Thank you. We'll get all the technology worked out in a minute. I want to start by thanking Sarah for such a nice introduction, but change it a bit. Because one of the things that I think makes this session unique is that it does what I do as a professional very meaningful. I'm a marketing academic, and marketing focuses on bringing the voice of the consumer to the forefront. And that's what we've been talking about all day long. So it's natural for me to think about the patient as the consumer of the services and products that we offer. It feels right to be doing patient-centered outcomes research, and it feels right to have the patients involved and engaged in everything that we do as health professionals. So I'm honored to have the opportunity to hear from our panelists, and I'll have to admit I'll probably chime in a little too because I'm a member of one of the projects that's underway. So let me introduce our panelists. Julie Day. Julie is a family physician. She is, I'll probably get your title wrong, but she's medical director of quality for the university community clinics. And in that role, she has had a lot to do with the development of some very interesting advisory committees that are helping the community clinics bring the patient's voice to them. So Julie will be talking to us. Rachel Hess, a lot of you are familiar with Rachel. She is an internal medicine physician, is director of the HSIR, which is Health Services Innovation and Research Center here on campus, and a faculty member in Population Health Sciences. And Christie North, a lot of you know Christie as well. Christie is the executive director of Utah's Leaving Well, which is an organization that is bringing to the forefront conversations about advanced directives and planning care at end of life. Christie is also my co-investigator on our PCORI project, and that's why I'll have to chime in, because when she's talking about our project, I feel very invested in that. So with that quick introduction, I'm going to ask, if I can flip this. I have put some questions up here just to kind of keep us focused. I want to first ask each of the panelists to talk about what they have done with regard to patient engagement in the various organizations that they represent, and to talk a little bit about how patient-centered research has impacted their activities, either in answering research questions or, for most of us, in actually operationalizing the results and getting the results of our research into practice. So Julie, can I call on you first?
Sure. I think I am plugged in. Terrific. Thank you for this opportunity. My interest in engaging patients dates back many years. It probably goes back to one of my early IHI conferences where I heard patients talk about cystic fibrosis improvement from Cincinnati Children's Hospital. And ever since then, I have been to multiple conferences where we talked about patient advisory boards, patient input. So it was a long goal of mine to help our organization move in that direction. So I'm happy to say that in the community physician group and the community clinics, we did have the opportunity of putting together a patient advisory board. We went to multiple conferences and tried to learn everything we could about how to make this a successful endeavor. And I felt like we needed a certain amount of structure, and I thought, what are the most fundamental things that we might ask these patients to participate in and to share ideas around? And I ended up looking way back to the Institute of Medicine's 6 aims, because as I had looked at multiple constructs and structures, these seemed to be the most fundamental. Probably all remember those: safe care, effective care, patient-centered, timely, efficient, equitable. And lo and behold, when I looked at our organization's operational plan, there was perfect alignment between where our system was trying to head and those same kind of goals. So we thought, well, we'll center our conversations around those topics with our patients. We solicited patients from our providers, so we asked our medical directors if they would help find patients. We were looking for patients that had a lot of experience within our healthcare system, people who might be interested in helping us make improvements, people who had maybe a broad view and could get outside of their own individual experience, people who felt comfortable talking within a group, and even people who had some time that they would be willing to help us work on those things. We expected that they would tell us their stories, they'd share their experiences with us, but also give us advice from their broad range of experience in life and different career trajectories that we could capitalize on. Boy, that turned out to be true in spades. It was amazing. And I think all of that groundwork that we did to make a successful board was useful, but it just kind of took off on its own. And they were very willing to collaborate and share their experiences. So I wanted to share some of the topics that we have taken up with that group and some of the kinds of advice, so you get just a feel for some of the ways they've been contributing to our operations. The very first meeting that we had, we shared with them some of our quality data around HPV immunizations and chlamydia screening. We had this idea that we were going to send a letter out, and it was going to explain all of the health maintenance things that were appropriate in this age group. And they gave us great feedback, like how a parent would feel if their adolescent got this letter and how it might be more useful. They actually wanted more detail than we had included. So really instructive and good detail. Some culturally sensitive issues came out, some age-sensitive issues came out, and it really helped us change the way we were looking at that. At one of our other meetings, we wanted to share with them what we were doing around population health management. In our clinics, we've been putting in some ancillary services, so we've been embedding in our clinics care management and social work and clinical pharmacy. And we had a very nice brochure that we had been designing, explaining each of these roles and how this might impact them, and so they would understand what this was about. They basically said, well, nice brochure. But what we're really looking for is really personalized care. What we'd really like to see is a picture of our care team with their names, who's on my individual care team, and what about a phone number to call? And could you give every member of the team a business card? And what we really don't want to feel is like you are putting a team in between me and my doctor. So it was very much about this personalization and not a piece of marketing. we had the director, we have a centralized call center in our organization, and our director wanted some feedback and some information about how patients would like to be contacted with reminders. Would they like email or phone calls or texting? At what kind of interval would they like to be contacted? And some of the information that they gave said things like this. Well, we'd like text similar to eVites, where the appointment could be clicked into our calendar and then have a map provided, and then, oh, by the way, we'd like to be able to accept or decline the appointment in that text. Pretty nice. A member commented that he'd like to be reminded to go to get his labs ahead of time before his appointment so that the labs would be ready for discussion. One of our directors out of our billing department was interested in putting some transparency around our billing so that self-pay patients would have some idea about what charges they might be looking at if they were going to have some kind of procedure. It also linked to a provider website where provider satisfaction scores were listed, and patients could look at various provider satisfaction scores that might be part of this procedure that they would be anticipating. So they wanted feedback on that, and they got the kind of feedback that we think we understand this, but the terminology is a little complex, and if you would put at the top of this infographic a number to call if we have questions. They even went so far as to say we don't like the term financial counselor because that's who's doing our 401ks, but we think you could say something like this. If you would like to verify that this is the right procedure, call our financial advisement team. So that was interesting. We talked about the patient experience in one of our centers that were struggling with our patient satisfaction scores. They said they really appreciated having greeters at the door that could guide them to the appropriate place in the center. They said, we'd like daycare, we'd like childcare here at the center. And they said there was some concern over the confidentiality of the survey, whether or not it was truly confidential or patients would know what they were saying in that survey. And then they said, you know, we think that you could increase the number of surveys you're getting if you did a short script about how it's used, why it's important to you, why it matters. So we get that kind of feedback. We had one program where we have, it's called Living Well with Chronic Conditions, and it's very successful when people go to it. We have really high patient satisfaction scores, but we've had a little struggle in getting the word out, in having people understand that it's there. So they gave us all kinds of input around that. Could you put teasers on the information line? Could you do a written prescription to the class? Get taglines from referrals. They suggested ask the participants to write a letter to their provider about the experience. And you could get taglines out of that, plus promote it to the physicians so that they might be more willing. Use class members to motivate other members. Put videos out of the experience. And then we did one question around what their perceptions would be of an intensive ambulatory care center for very high-risk patients. Patients said, I'm not sure I understand why we would do that. It seems like removing the patient from their core relationship with their primary care doc is a very big deal. Another patient said the patient-provider relationship's really important. I'm not sure I would like that. And one person said they would like it, that they would be willing to travel distances to go to that kind of a clinic. So we were receiving all kinds of really pertinent feedback from the patients. And all of this has gone to really shape the direction that we walk in our operational development.
Julie, that's fantastic. Dr. Montori started us off today thinking about the work of being a patient. they've just flipped it around. Look at all the work they've given us that we need to do to be able to respond to the things that are important to them. But hearing from them is the first step, to make sure that we hear their voices, to make sure we hear their concerns, to make sure that we know what's on their mind and don't just run off and do what we think we should do without input from them. That's what this is all about. So thank you for sharing that, Julie. Rachel.
Okay, I'm successfully mic'd. Okay. So I reflected a lot, and I've been reflecting a lot recently on the questions that Debbie asked us to consider. And the first, and I keep turning around to reading them because I didn't print them out appropriately. I think that patients and stakeholders have really been integral to my research since I started my research, but have grown more explicitly integral to research, if that makes sense. The first study that I did was one looking at the impact of menopause on quality of life. And if you ever want to find a group of study subjects who are more willing to give you opinions, you can't find them more than midlife women when you want to talk to them about menopause. And it's like you've opened this major can of like knowledge just sort of flowing through. And I happened to have this really amazing research coordinator who was also going to get her master's in psychology and counseling. So she liked to talk to people, which is a good thing in a research coordinator, but she's also very specific. So we got the data that we needed, but we always got kind of new ideas. And so this was a longitudinal cohort study, and every year we would sort of ask the participants what other kinds of information they wanted to give us next year. And so people wanted to talk to us about more about relationships. So we added more questions about relationships. And then we took those out because we didn't think we could just keep making things longer. And people wanted to talk to us about sexual functioning. So we added questions about sexual functioning. And people wanted to talk about, what's the other thing? Sexuality and gender identity. And so we added questions about sexuality and gender identity. And kind of with each one of these iterations, my mentors, some of my mentors would say, I don't know, I think you're going to turn a lot of people off who didn't want to talk about that. And inevitably, everybody was, the same people who didn't want to answer questions last year didn't want to answer questions. But the majority of people were really happy and felt like we were asking a lot of really important information. And those data really have fueled a lot about the way that I've thought about not only my research world, but my clinical world. And this was back in 2003, 2004, 2005 range. So not necessarily the time of the world when patient-centered research was really a thing. The biggest sort of thing in patient-centered research, I think then was CBPR, community-based participatory research. I knew people who did focus group research, but focus group research really isn't participatory research. It's a different data gathering tool, but there were these people who did community-based participatory research, but I didn't really think of myself as somebody who did that kind of work. I just thought that I was really lucky to have all these engaged participants who wanted to give me new ideas that I could write more papers about. So that was exciting. And we sort of made that much more explicit as we moved into doing more kind of health services implementation studies, and went so far as to sit down with the people who could be participants in our study. At this point, they weren't, but we got together a focus group of patients. Focus group is the wrong word. We got together a focus group / design session of patients who could be in our study, and sat down and said, we want to create this reminder system to help you do a better job of taking care of your health and know what's going on. What do you think of this reminder system? What would you do? We didn't have any we had what we thought we would do, but weren't very explicit about it. And got this design over the course of 3 sessions with this group. and then checked it with a completely different group, and everyone was really happy about the design. And basically, it was this design where you got a message, and then you waited 2 weeks, and then you got another message, and then you waited 2 weeks, and then you got a message and a letter. So it was a 3-cycle thing, and it could only fire every 2 months. So everything that you needed to do within that time period had to be bundled, because the last thing anyone wanted was like spam about stuff. And it's really interesting. So we are trying to make people more active and better participants in their healthcare, and decrease missed healthcare and increase preventive health services receipt. And the study failed miserably. We didn't actually increase anyone's receipt of preventive services, which is very sad. And the paper is almost done, which is great. So, but what worked was this reminder system. Like, you would think after this went on for like 2 years in some of the participants. And I was like, after like 3 cycles of this, people aren't getting stuff done. They're just going to start ignoring us in our reminders, right? No. Like 80% still opening their reminders at the end of 2 years. And at like 18 months, it was like 90. Like, it's this huge number. The reminder system worked. Like, we found a way to get people to engage with us for a totally not useful intervention. But we have a way to get people to engage, which is really exciting for those of you who are thinking, I have an intervention that I'd like to target to patients in a primary care practice. I can totally give you the intervention not to do, but I can also give you the system to say, but this is how we can get people, this worked. People didn't get annoyed, they stayed engaged, which I'm sort of a glass half full person, so I was like, yes, the system that we designed with the participants worked. The intervention that we designed with the researchers, not so much. And that's okay. We have reasons for that. You can read the paper. And then I got the first PCORI grant that I had ever gotten, and they were like, well, you have to engage with the stakeholders and the patients and the community. And I was like, well, everyone does that, right? Apparently, it's a little weird. And so we started talking about how to explicitly, this isn't just design, but how do we explicitly engage from the beginning? And so I told you that one of the things that I started doing in menopausal women was sexual functioning research. And so this is my favorite story ever. In our PCORI project, we had to engage these 3 cohorts as proof of concept. And we had these researchers and these clinicians. And so we had clinicians and researchers, which is better than usual when you just have researchers, sitting down and saying, what kinds of things would we want to know from patients with idiopathic pulmonary fibrosis that can help them in their lives? And for those of you that don't know, idiopathic pulmonary fibrosis is this progressive, rather acute disease that is only cured by lung transplant and can lead to death at some point between 6 months and 3 years, depending on when you get diagnosed. People are often diagnosed very late in their disease and really don't live very long. So we had this great list of things that we thought would be super important to idiopathic pulmonary fibrosis patients, like how short of breath they were, how active they could be, all of this stuff. And so we very proudly marched into several idiopathic pulmonary fibrosis groups and said, we are engaging with you in the research process. We are very excited about this. This is kind of what we're thinking about asking you about so that we can learn more about your disease and try and help you be healthier. And they read through our questions. They were very excited. Everyone was very excited. And we got the most bizarre, at least to the clinicians and researchers in this area, feedback, which was, there's nothing in here about our sex lives. And I was like, yes, I have something to contribute. I know nothing about idiopathic pulmonary fibrosis, but I can talk to people about their sex lives. And they're like, this is really important. And everyone, the researchers and clinicians were all like, seriously? Because you have like 6 months to live and you can't breathe. But okay, And so I, being the dutiful sex researcher that I am in my other life, was like, this is the best instrument. It's this measure from the patient-reported outcomes measurement information system. It's computer adaptive. It asks about everything. And they were like, whoa, that was more sex life than we wanted to talk to you about. So I said, okay, that's okay, I have a backup plan. So we used this lovely questionnaire that was developed for midlife women, which was what we had been using in our studies. And men in their 70s seemed to think that that was the right appropriate amount of sex to talk about when they had idiopathic, right, which is bizarre, right? So I think that the point of all of that is that engaging participants and stakeholders clinically or in research or in any other aspect, talking to the people for whom you want to gain information about, hopefully so that you can help make lives better, is actually super important. And it makes your research better. And it means that you're asking relevant questions that may actually change someone's life. And we all like questions that are just interesting, but the ones that are relevant that can really improve people's health, I think are kind of cool. And so I feel like that engaging with patients and with my participants has been huge in changing the way that I do my research. But also as I think about outcomes research, if you don't have outcomes that are relevant to the people for whom you're conducting research on, then they can be the best outcomes ever and the most relevant outcomes to health systems and clinicians, but may not be relevant to the people whose lives you're trying to affect. So when we start talking about this, I'm like, okay, yeah, but why would we ask that? Like, how would we even get to asking that question? It just should happen, but I think it's an important one to answer.
Thank you, Rachel. I think one of the things that Rachel's stories illustrated for me was if you don't give value back to those that you're trying to engage, they won't stay engaged. But if you strike that sweet spot where you're finding something that's meaningful and relevant to them, their engagement will last forever and it won't be work, as Dr. Montori was talking about this morning. I was thinking about that afterwards. We're asking an awful lot of additional things when we get patients involved and in our work. But if we do it the right way and are conscious of making sure they're getting value from that relationship, it isn't perceived as work. Thank you for saying that. Please.
Sorry, one thing after that, which is just the other thing that Victor said this morning that I thought was really important was this concept of taking care of the whole patient. And I think to Julie's kind of engagement within primary care, if we engage a person, we can engage people well. If we engage diseases or organ systems, and we engage a lot of those, we have trouble engaging a person. And I think.
Thank you, Rachel. Christie.
Okay, does mine work? Or am I going to be the only one who failed? Oh, good. When I first realized I was going to be talking with these esteemed colleagues, I thought, I'm not sure that I have anything I can add. That's never true because I can always add something. It's whether or not you find value in it. I first knew that patient-centered care was the right thing to do in 1980 when I dropped by a patient's room to tell them that we were going to be performing a bone scan to find out if they had metastatic disease. And as I left the room, the patient's wife followed me down the hall and literally grabbed my arm and said, "You're not leaving until you tell me what you're talking about." And the patient had not been informed that he had prostate cancer. So me saying that I was going to be doing a study to find out if he had metastatic disease from this cancer was a little bit shocking. So at that point, I sat down with this wife for an hour and I broke many rules of the old hospital systems, and I told her everything I knew. And she was so incredibly thankful for me to just engage with her. So at that point, I knew that that was really important. I found a book. Cornelius Ryan wrote all sorts of World War II books. He wrote one book that he didn't actually get to publish because he died in the process, but it was about his struggle with prostate cancer. And one of the key points was You go into a hospital, an institution, and they take you away and turn you into a patient. And I read that book annually because it humbled me every single time. And I remembered that there was a person inside that disease, and it was very, very helpful. So I spent 30 years in healthcare administration. And over those 30 years, there were a lot of changes, but there were a lot of things that didn't change. And I think there were still patients who didn't know they had prostate cancer when they were being sent in to have a bone scan. But we've made huge strides in that. I had the great privilege of being the primary caregiver for my mother-in-law a few years ago. And Debbie Scammon was my professor in grad school, and we'd stayed in touch. And we were comparing notes because she was being a caregiver to her aunt in California. And we were saying, you know, what some of the challenges were. Yes, it's great. I'm getting to know her really well. We're being very close. But at the same time, I never know if I'm doing the right thing. I don't know if I am crossing these medication lines and giving her more, or not giving enough, or giving them at the wrong time, or how to set up the oxygen machine, and whether or not the pulse oximeter is doing what. So we compared these notes, and we said, there's probably other people that are as frustrated as we are. And we found that as we talked about this, everyone was as interested as we were. Everyone had had an experience being a caregiver, either as a primary caregiver to someone who was in their final years of life, or often parents of sick children who have a very different role in caregiving. But we found people were really interested in the topic. We were meeting with a research group. Mike McGill was leading this research group, and we were talking about things we might research. And we looked at this as an idea, and about the same time, PCORI came out with this, I call it a grassroots effort, because what they wanted to do was to get patients involved in setting up the process of doing research. Not just to be the subject of the research, but to really be a part of the beginning steps in the research. And as it turns out, Debbie and I, without affiliation of any large organization, applied for this award through PCORI. We thought we got it because we didn't ask for any money for ourselves. And that still may be true, but we were focused on engaging patients and their caregivers and finding out what it was like for them. And that was the tier one, taking care of our parents, elderly people who take care of elderly people. And elderly, you know, has so many connotations, but people who are adults taking care of their adult parents, grandparents, uncles, aunts, etc., or sometimes just friends. Because being an informal caregiver doesn't necessarily mean it's a family member that you're taking care of. It just means that you are there day after day trying to help them get through this illness that by its very nature, chronic disease doesn't go away. So it's a continuing process. And as Debbie and I were shocked to find that we were awarded the PCORI Tier 1 and asked to build a community, Brian and Ben both have the same experience with PCORI. We began to engage other people to talk to us and to set us straight and to tell us what their experience was. And people were delighted, first of all, to tell their stories. They wanted to talk about their experiences, and they were not shy about talking about their we didn't talk about sex, though. But they wanted to talk about what they were going through and some of the frustrations. People were very quick to point out, it is a pleasure to take care of my sick spouse. Or I am so glad my mother and I have had this time together. And the other side of that coin is, it's very frustrating to never know if I'm doing the right thing. Because I don't care if you are a geriatrician, when you start taking care of your own parent, questions arise that you have to scratch your head and say, is this what I was supposed to do with this? I don't know exactly. So it's not just unskilled healthcare workers, but it's everybody has some frustration with that. So we learned that PCORI was very serious about going to the grassroots, to getting patients and their caregivers involved, and to seriously say, well, what do you think we should be researching? One of the early lessons we brought together a huge group, huge is not quite the same in the Bernie Sanders isms, but a fairly large number of caregivers. We tried at first to talk to patients, and what we found was patients didn't have the patience to sit down and talk with us. Caregivers were willing to talk about the problems, but they didn't have the time because as a full-time caregiver, it was hard for them to get away and go to meetings. So we often had to meet them in their homes. We often had to do it by phone. We often had to, do a focus group, if you will, of 2 people because that's all we could get together at a time. But we listened to what they had to say. We asked them to advise us, and the first thing they said was, not the first, there were a lot of things. We don't want to just sit here and say, yes, you guys are doing the right thing, you have the right ideas, yes, go ahead. They said, we want you to listen to us about what you should do. So they really challenged us to not put out what we thought was right, which is what we do in healthcare to a large extent. Here's what we should do. Okay, that sounds good. They wanted us to say, here's the question, what shall we do with it? And they've been very, very helpful for the last 2 years in helping us prioritize what the important challenges are. So I'm not sure that I addressed any of the questions that Debbie has developed. Debbie asks me to speak to her marketing classes from time to time, and I never talk on the subject she recruits me for, but we always have a good time.
Thank you, Christie. You did just great. So I think I've got a mic that's working now. Okay. So you said a couple of things that were on point with what I was hoping to discuss, and that is our experience with our small project was exactly as Christie just said. The participants with us in our community, they are our community. They don't want to just validate what we think we've discovered. They want to lead us to what's the thing that is important to them. And they force us to follow them. We have become great friends. We had a end of program meeting at the end of Tier 1, and I think we all shared a few tears with each other over what we had learned and bonded around each other. The experiences that we'd shared. We're getting ready for our end of Tier 2 project, and one of our community members has invited us to his home to host a dinner for us. That's the kind of relationship that has been built just because we were willing to listen, because we were willing to ask what's on your mind, what's important to you. And I think that that's a huge lesson for all of us to learn. So thank you, Christie, for sharing that. So I have just provided a little bit more of a roadmap. I think we've actually hit on what the primary benefits are. We've been talking about that all day long, what the benefits of engaging patients and listening to the outcomes that matter to them. A few of us have talked a bit about the challenges. So if there are any in the audience that would like to add to benefits or challenges that we haven't articulated, please, now's your chance. Any thoughts about, I think particularly the challenges, those that have maybe just started to put their toe in the water in this big pool. You may be thinking about some challenges that are stopping you from going further, faster. We'd love to hear. If not, then let me move us to the last question, and that is one I think this whole session today has been about. If we truly believe in this patient engagement initiative, and if we truly believe that patient-centered outcomes are at least part of what we as researchers and clinicians ought to be thinking about, where will we have the biggest impact? Where can patient engagement and listening to the patient have the biggest impact? Any thoughts from our panel?
I always have a thought, and I'm always willing to share it. As I thought about this, what's the biggest impact that patient and stakeholders can have? I think it's to ask patients and stakeholders And I think if we just remind ourselves that there's a perspective there that we don't learn in medical school, that we don't learn in any sort of a clinical upbringing. It is that patients and their caregivers have a perspective that is important. We heard the young mother, I'm sorry, for Jordan, talk about how it was so important that her physicians would listen to what she had to say about her child and help her work through that. And I think if we just say, oh yeah, patients, caregivers have an important perspective. Now let's make sure we understand what that is and not be paternalistic in terms of saying, oh, we know what your problem is and we're going to help you fix it. Tell us what you think the problem is and how we might go about fixing it together. So I think ask and listen.
Rachel, you started to touch on this when you revealed your own initial forays into this, that you didn't, that it was something new, and that it doesn't come naturally to everybody, and it may not come naturally to physicians who have been highly trained to be making decisions about what is right for their patients. Is this an area where we can have an impact?
I think that it's a huge area that we can have impact, and I think that actually one of the largest areas that we may be able to have impact is not in developing new science or new interventions or new procedures, but in trying to understand what of the plethora of work that we have done we should start implementing. And I think about the struggles that I see. I have clinic this afternoon, so the struggles that I see kind of on a very frequent basis with my patients, who I seem to have this string of people with body mass indexes of 40 in the last few weeks. I don't know why. And for those of you that don't know, 40 is morbidly obese. So people for whom their weight is probably one of their biggest risk factors for their health and for their future lives. And we have things that we know we can do to help them, but some of those are cost prohibitive for people who basically aren't in the top 10% of income earners in the United States, quite frankly. But we don't have a lot of ways to get these to people in cost-effective ways, or ways that we even think people might want them. And so I think that talking to patients and stakeholders can have the biggest impact in helping sort of derive what we do in patient-centered outcomes research, or implementation science, or comparative effectiveness research, or whatever the new buzzword is we're going to use next year for the same thing, as far as I can tell. They're subtly different, but close enough. But also for how we define the benefit packages that we put together for our insurers, and how we define the benefits we put together in our healthcare systems. So I think it goes beyond patient-centered outcomes research and goes to the biggest impact on patient-centered outcomes, or on patient outcomes.
I was sitting here thinking, sometimes when people ask me what I do, it's a little hard to explain what working in healthcare delivery is, and I try to talk about making the delivery system better for them. It's a very broad topic, and as you can see from sort of the examples that I shared with you, it crosses all kinds of areas of interest. Two things that I have found interesting is people across the university have been interested in having this assemblage of patients that they can tap into, because they do have very real questions within all of their operational structures. Our call center wanted to know, what is the best way to do this? Finance, billing, wanted to access them and say, how can we make this easier for you? All of that plays into healthcare delivery and improving the healthcare delivery system. And as we assembled this team of patients, I think what has been interesting is the diversity of their backgrounds that they bring to all of these different areas of inquiry. We have people with IT backgrounds, we have a social work background, we have people who have been in the business sector. So all of these people have such a rich source to bring to new eyes to us. And I think it is really the outside eyes, because we end up talking in an echo chamber to each other and saying, yeah, I think that's right, it's all good, like Rachel with her researchers. But having this rich, very rich resource with very varied background has been an immense help in bringing new eyes to problems that we've just seen things in a way that we don't see it.
That's great. So I'm going to end with just a couple of things and then turn it back to Sarah. I started out by saying that I was a marketing academic, and one of the things I always tell my students is that the thing that I like best about marketing is that it's externally oriented, not internally oriented, and that's what we've just heard. Looking externally and getting the perspective from those that are out there in the community that we hope to be interacting with, bring them to us. Don't just look internally at what we think is the best practice. Please.
I think you have missed a very important point on the last question. PCORI grades very highly on dissemination of information, and that does not mean publication. It means having the patients disseminate that information.
Absolutely. Thank you for raising that. I'll try to tie that into the second point that I was going to make in conclusion, and that is that PCORI, those of you that have applied for any funding from PCORI know that one of the things that they ask you to do is have a principal investigator format for your projects, and that those principal investigators need to come from more than one domain. So they should not all be researchers. They should be a researcher and a clinician, or a researcher and a patient, or a researcher and some other stakeholder. And so that's trying to broaden that out. And one of the important things that they want to bring the other stakeholders into the process to help with is the dissemination of the findings or the learning that you have throughout the project. So I thought the example this morning of we started out with a newsletter for our research team, and that broadened to a newsletter that now goes out on Facebook and is in the community. We've actually tried to do a little of that ourselves with our small project, and it's been very well received. So translating the research and the clinical findings into vocabulary that's understandable and getting it into venues where it will be heard and seen by the people that you're trying to communicate with. Very, very important.